summer, I had the privilege to travel to Haiti to explore Haitian women's barrier to cervical cancer prevention and control. So I'd like to revisit some background that my colleague Lindsay shared earlier about globally, low and middle income countries experience the excess burden of cervical cancer. Particularly, Haiti has some of the highest rates reported in the Western Hemisphere. Notably, here in the United States, both incidence and mortality from cervical cancer have been significantly reduced through screening and other pervasive, widespread prevention measures, such as vaccination. However, disparities still persist, particularly in immigrant populations. For instance, in South Florida, where the largest enclave of Haitians are here in the US, there's a disproportionate burden of cervical cancer in the population as well. So there's some long-established risk factors for cervical cancer, and particularly HPV has been cited as the major causal factor for cervical cancer. So that includes early sexual debut, multiple sex partners, as well as impaired immunity in addition to smoking. More recently, some cofactors also have been identified, such as lack of access to, as well as underutilization of routine screening. So the purpose of this mixed methods, community-based participatory research study is to understand what exactly are the considerations to deconstruct the barriers for cervical cancer prevention and clinical care for Haitian women. And that's within the context of both cultural and ecological systems for public health planning and delivery. As this is a women's health project, I have references here of some very, very key figures in Haitian history who are women. So this study is part of a 3-paper dissertation option. Just to give you some context, the first part of my dissertation is quantitative in nature, which utilizes a data set to retrospectively analyze what is the profile of a woman who reports not having been screened for cervical cancer. And I use multiple types of statistics, including machine learning, in order to have better, robust understanding of what that may look like. Inferences from that aim guided a geospatial analysis where I visualized where exactly these women are living in South Florida. With that information, that guided this third qualitative portion, which was transnationally based in Haiti. All 3 of these pieces of my dissertation are geared at understanding how can we best approach cervical cancer screening for prevention and control. Again, particularly I'll be focusing on the qualitative aim, which was supported by the CEASE grant. I used the PEN 3 cultural model in order to organize my assessment and approach with guidance, and particularly cultural empowerment is how I map on the theoretical underpinnings to assess this qualitative aim. Overall, the PEN 3 cultural model really encourages us to understand the populations that we're looking to serve, these vulnerable, diverse populations, from a lens of culture as a factor that can be empowering. So I'd like to give some information about the research team. So again, I'm a doctoral student at the University of Miami, and fortunately, my mentor has had over a decade of interdisciplinary experience and collaboration with stakeholders not only in South Florida, but also in Haiti, which provided the infrastructure to do this study. Particularly, I partnered with Zami La Santé, which is the largest non-government healthcare provider in the country. With that, there's some key personnel in Zami La Santé that really provided some incredible insight into how to do this project, including the Director General, as well as the Women's Health Coordinator. In addition, particularly my on-site mentor, Elizabeth Campa, who also serves on my dissertation committee, who's the Senior Health and Policy Advisor, as well as the Director of Research for Zami La Santé, Dr. Mary Clisby, and most definitely my day-to-day personnel, Mrs. Fanfan El Cize, who's a midwife based at the hospital that we did recruitment at. So the study is situated in Artibonite, which is one of the largest departments in Haiti, particularly in Saint-Marc, which is a coastal city. Again, recruitment was done in partnership with Mrs. Fanfan Eslize, who is a midwife and also the chief representative for women's health services at the local hospital. Eligibility included 25 women for saturation who were ages 25 to 65, who self-reported as having not been screened in the last 3 years. Again, as my colleague Lindsay mentioned, in under-resourced settings, pap smears aren't quite accessible or cost-effective and efficient for people to be able to undergo. So indeed, VIA, visual inspection with acetic acid, is what is used in this location. So we used Photo Voice. Just by a show of hands, anyone familiar with Photo Voice? Okay, wonderful. So just to share some information, Photo Voice is a research tool that empowers women to identify, represent, and enhance their community. Essentially, we use digital media as a tool to guide scientific investigation. So women were recruited and consented. So here you see is a meeting at a local restaurant, how we did the consent process, where we, of course, described the study in detail. And if women were interested in participating, then we showed them how to use digital cameras. So that's precisely what you see there. And right to my right, your left, is Mrs. Fanfan El Cize. So she was also there to help facilitate. And so women were prompted to capture digital images that represented their barriers to accessing gynecological services, particularly cervical cancer screening. They were really, really encouraged to be fully artists in their understanding and capturing of these images. They were given 5 days, which allowed for both weekday and weekend exposure in order to capture these images, and then were individually interviewed to describe and sort of, unpack what images they captured. From there, if they were amenable to focus group participation, and by that I mean someone who wasn't too timid, and also a balance of someone who wasn't overly talkative, and someone who was very able to articulate what those images were, they were invited again to participate in a focus group interview for data triangulation. So the initial results were organized into 7 categories. So with this PowerPoint, I shared this with the women, of course, and so that's why you see it also in Haitian Creole, and I put it in English, so this will also be a language course mini. So one particular area was discomfort, and I'll go into detail about each one. Also time. Additionally, gendered familial duties served as a barrier to accessing gynecological services, as well as financial restrictions, so COB, money talks, quality of care, misinformation, and also emotions. So for the initial results, there were 2 subcategories within discomfort. Particularly, women were very, very uncomfortable with the speculum. And the narrative behind it was the fact that it was made of such a rough, hard material, and women weren't familiar with the process. So the question was, how is this going to be put inside of me? Is it going to hurt? Additionally, women were concerned with sanitary applications of the material. Also, with discomfort, women were extremely uncomfortable with nudity. And so whether it was a male or female physician really didn't matter. It was just that intimate space and sharing that made women very unlikely to want to even go do the exam. Also, with gendered familial duties, caretaking was a major concern. So here you see a participant capturing the necessity of caring for an elder. That responsibility includes time and energy that serves as a barrier to even going to seek services. That also ties into caretaking for children. Notably, quality of care was a concern. So part of that quality of care, one of the subgroups, sub-themes was that there were group consultations held at the hospital. So notably, in the under-resourced setting, the time limitation really was prohibitive on the nurse to be able to take time and speak with everyone individually. So there would be group consultations. As you see here, there's blood work results being shared. And so women described that they were incredibly uncomfortable with this, as you can imagine. And even that posed an issue where women weren't being authentic with what their health history was, in fear of having their information shared with the community. Here also on this slide is misinformation. So the pictures there were a bit more difficult to visualize, but in the interview process that came up as a theme, and women again talked about their either lack of awareness of cervical cancer in general, so not knowing that they should be screened triannually, as well as the feeling of cervical cancer being a death sentence. Whereas if identified early enough with screening, you can do the see and treat method again, as my colleague shared earlier. Notably, women were very concerned with staff disposition and were very in tune with how a healthcare provider may be sharing their health information with them. So they noted that perhaps the health professioner's face signified that something was wrong, and that interaction was a very adverse experience where they didn't even want to go back to another healthcare professional. Also with quality of care was that with staff disposition, sometimes the staff were occupied with other things. And that also, again, ties into the under-resourced setting where people may not be able to give you their full attention because of their own needs and necessities. Notably, women were also able to identify that they were in an under-resourced setting and gave narrative to the perspective of the healthcare professional, which may not be getting paid on time or being paid sufficiently or have their own personal problems that they bring to work just by virtue of being human. To share some additional results, this picture is a little difficult to see, but and something that came up was travel. So this is an image of the water at 4 a.m. So if you could try to focus and see, again, with this was a description of a woman who lived by the sea. She had to wake up at 4 o'clock in the morning in order to catch transportation to the mainland. Not only was that a challenge, getting back was another, because the last boat to return was around 2 or 3 p.m. If you didn't catch that boat, you were essentially stranded. Also with transportation was transportation by land. Women shared that they may live in more remote regions where the road may be difficult, and taxis, motorcycles, which was a very common form of transportation, either wouldn't come by those areas, or if they did, they wouldn't stop. And so in order to catch a taxi, they had to walk 30 minutes to the main road, and then there was an additional 10 minutes on the taxi ride over. Significantly shared by the majority of women was the long wait for services. So here you see a line of people trying to, get their information processed. However, it's hot, you're hungry, you're waiting for all day, and that ties in back to the issue with travel. So for instance, the woman who has to get up at 4 a.m., catch a boat, make it to the mainland, wait, and potentially miss the ride back because of a long line is an incredible barrier that really isn't appealing for her to want to seek those services. As you see the woman in, I would say, the end of the line, but it's not technically the end of the line. This is just what the participant was able to capture in a picture, and they said that specifically, has a towel overhead because it's so hot. Moving on to another theme was financial. As you see here, there's a woman who's looking in her wallet and she doesn't have money to pay for services. And that's money not only for services, but transportation, for instance. Also, women mentioned if they go to a health facility for services, then there's financial loss in a way because they're not working. So this is a woman who is a beverage distributor, particularly carbonated beverages, and she mentioned that she needs to not only pay in order to refill the bottles, but has to physically be there in order to distribute. Something additional that was very, very telling was the emotional aspect of seeking services. Women were very, very emotional about it. They shared sentiments of fear or despair regarding the results. They were also timid, so sort of less likely to advocate for themselves in a situation where they may not understand the results, for instance. They also described anger and frustration given their barriers, and also a general lack of support. So for instance, with lack of support, women shared pictures of them working and trying to leverage some communal aspects of having someone cover for them if they wanted to displace and go get services, but also noting that the person might say no. And if they said no, then they were very, very saddened by that reality that they couldn't go get health care because of their situation. So those are the overall results of the study, but I'd like to tie it in to how this not only helps us identify public health targets to address these barriers, but this also enables us to understand a vulnerable population in a way that is very direct, whereas had I spoken with healthcare professionals about why women may not be coming to get screened or what their barriers are, they wouldn't be able to provide me with this level of detail. Additionally, what was really informative about the photo voice process, which enables women to not only think and identify what their barriers are, but also describe what can we do about it. So this study suggests the need for education, particularly the women suggested after learning more about cervical cancer and the screening and prevention methods that it would be useful to have this information more widely available so misinformation could be addressed, for instance. Also, women were very empowered to not only get screened themselves, but also share this information with their communities. And with empowerment, they really wanted to shift the cultural narrative of women being burdened with the familial duties, but also share that with the family unit, so that didn't fall upon them solely. Finally, women also recommended some deep evaluation. For instance, with just the formatting of healthcare, how can we start to shift perhaps the issues, for instance, of long lines? So women also endorsed the utility of mobile clinics and community health workers serving as liaisons between them and the health infrastructure. So lots of lessons learned. First and foremost was the bureaucratic process being incredibly intensive. So I started developing these relationships in the spirit of community-based participatory research since 2017. I got IRB approval in 2018. However, due to, and to rewind, with IRB approval, not only did I need university approval, I also needed in-country Zami La Santé approval, which I think is quite standard. However, there was also the need to facilitate service agreements between the university and the organization, as well as data usage service agreements. So that literally took over a year in order to be able to execute the project. However, with that, I really learned about the importance of relationships and research and how it's so critical to have community buy-in in order to really see a project like this through. Additionally, in-person meetings are incredibly powerful and even more so preferred because you get just a continuity in exchanging and direction, and directly connecting with someone that is very, very powerful and particularly in this context, culturally important. So I imagine my future career developing into a global social cultural alchemist. So that really encompasses how can we develop and engineer systems for health equity for all. So particularly with this study, as I shared, there's a lot of women's health issues that are coming up, and I'm really interested and passionate about how can we start to shift these systems in order to promote wellness. As we know, particularly again with this example, when women are well, we all are well. Women in this study described being the caretakers of their family. So in order for the family to be well, the woman, of course, needs to be well herself. I'm really passionate about social entrepreneurship, so we can see how can we put these solutions and policies actually into practice. How do they play out? So future students and site considerations include, one, the strength of this study was the partnership with Zami La Santé, because again, they really provided that infrastructure in order to execute the study. It would be incredibly difficult for me to show up as a US-based researcher and try to just recruit women. So it was really, truly a big shout out to Ms. Fafan El-Cizé. Oh, this isn't advancing alongside this, but I have a picture here with Ms. Fafan El-Cizé, who again was very, very paramount in that process. She knew the community. Everyone, while we were walking on the streets, greeted her. So there was a understanding of the just that social connection that, these are digital cameras that cost over $100 each. So they knew that, she knew that they would return the cameras, for instance, rather than disappear or maybe not take good care of them, for example. Another strength was the location of the study in Artibonite, because again, it was one of the largest departments in Haiti for recruitment. I did want to share a few limitations that included the capacity of the participants. So with a study like this, it's incredibly crucially important for participants to understand what exactly the research question is. However, a few participants did not grasp what exactly we were trying to understand. And so, for instance, they returned pictures of like themselves or their friends, which was nice but not quite useful for the study. Also, the limitation was preoccupations of personnel in under-resourced settings. So, for instance, Ms. Fafan was literally building her house. She had a one-bedroom studio with a child and has worked for the government for over 2 decades, but has not been able to secure her own space. So the last day, when we were doing focus group interviews, for example, she came incredibly late. And part of me was like, come on, it's the last day, is this how the study ends? But in that same vein, I had to not take it personal and understand that this is her life. Her life. So understanding that limitation in that setting. Additionally was the time availability for the study. Was that Haiti right now is going through incredible political turmoil. My project was delayed over a month, and that's with the practicalities of it due to the political unrest. So I called Dr. Solomon a couple of times, like, I don't know, might have to do this locally in Florida. I don't know if I'll be able to go to Haiti. And he was incredibly patient with me and encouraging, so thank you. So for future students, I have some insight that perhaps it'd be interesting to try to see how can we implement remote screening and telemedicine, for instance, as well as the dissemination of education. So again, issues like misinformation could be addressed. Finally, also programming for empowerment to start to shift these cultural narratives. These are my references. I'd like to give a big thank you.